This conference will now be recorded.
Start it. Hello, good morning to everyone. Sir, వినపడుతుందా? Hello. So today's topic for discussion is dizziness and vertigo. So this is the terminology. Dizziness means imprecise symptom used to describe variety of sensation. So dizziness means so all together some of the symptoms which are grouped are called as dizziness. So these symptoms are vertigo, lightheadedness, faintness, and imbalance. All these clubbed and called as dizziness. So specifically, vertigo means abnormal perception of movement of the environment. Abnormal perception of movement of the environment occurring because of an abnormality in sensory information from eyes, limb proprioception, and the vestibular system about person's position and space. So physiologically, there is a sustained head rotation and pathologically due to vestibular dysfunction. So vertigo is maybe physiological sometimes due to sustained head rotation or sustained body rotation, and it may be pathological due to vestibular dysfunction. Lightheadedness, pre-syncopal sensations due to brain hypoperfusion. Lightheadedness means pre-syncopal. It is a pre-syncopal sensation due to brain hypoperfusion. At times, word lightheadedness may be also referred to disequilibrium and imbalance. So these are the causes of dizziness. Dizziness means vertigo, imbalance, everything we have discussed like vertigo, lightheadedness, and faintness and imbalance. All these are clubbed and called as dizziness. So these are causes for dizziness. So some vascular disorders like vascular disorders causing pre-syncopal dizziness and dizziness upright posture and brief source of dizziness. So vestibular causes include vertigo and imbalance. So these vestibular causes can be divided into peripheral and central causes. So peripheral causes include benign paroxysmal positional vertigo, vestibular neuritis, herpes zoster oticus, Meniere's disease, perilymphatic fistula, semicircular canal Dayson syndrome, Cogan syndrome. All these are otitis media also vestibular cause for dizziness, and central causes for dizziness include vestibular migraine, brainstem ischemia, cerebellar infarction and hemorrhage, Arnold Chiari malformation, multiple sclerosis. All this can cause central dizziness. So some non-vestibular imbalance and gait disorders include loss of proprioception from posterior column. That means posterior column will carry the vibration and position sense. If we lose the posterior column, we can lose the proprioception. So that will lead to non-vestibular causes of imbalance and gait disorders. So anxiety is also cause for dizziness and vertigo. The causes of vertigo and dizziness include so general systemic causes include hematological like anemia and hyperviscosity, cardiovascular causes like postural hypotension, carotid sinus syndrome, dysrhythmias, and arrhythmias like atrial fibrillation can cause vertigo and dizziness, and shock can leads to vertigo and dizziness. Some metabolic causes include hypoglycemia and hyperventilation. So these are the general systemic causes for vertigo and dizziness. Neurological causes include supratentorial causes epilepsy and syncope, infratentorial causes multiple sclerosis, vertebrobasilar ischemia, and infections like syphilis and tuberculosis, cerebellopontine angle tumors, foramen magnum abnormalities. All these are the neurological causes for vertigo and dizziness. So otological causes means there is some problem in ears. These include Meniere's disease. Meniere's disease is the main cause for vertigo and dizziness. The earliest manifestation of Meniere's disease is vertigo and dizziness. And post-traumatic syndrome, positional vertigo, vestibular neuronitis, and perilymph fistula. labyrinthitis, so vascular accidents, tumors, all this can lead to vertigo and dizziness. So how will you approach to the patient? So you have to take the thorough history like unilateral, bilateral, or acute and chronic or progressive. Or we have to take the history whether it is unilateral or bilateral, or whether it is acute or chronic, whether it is progressive or non-progressive. So we have to take history of duration. If it is if it relates to minutes, so we have to suspect uh, if the symptoms uh, develop within seconds. So we have to suspect benign proximal positional vertigo and orthostatic hypotension. So this benign proximal positional vertigo will changes with the position of the head and body. So orthostatic hypotension means when you suddenly get up from supine to uh, standing position, so we can feel the dizziness. So it will develop in within seconds. So minutes, if the symptoms develop within minutes, so we have to suspect uh, transient ischemic attack or posterior circulatory migraine. So if symptoms develop within hours, we have to suspect attack of vestibular migraine or Meniere's disease. So we have to know whether it is a first attack or not, whether any provoking factors are present or not, any accompanying symptoms like headache, hearing loss, or ear pain, or pressure of ear or fullness in the ear. These all the symptoms can suspect. We have to suspect in peripheral disease like ear. So there may be sometimes double vision, numbness, or symptoms suggest of brainstem or cerebral lesions can be present. So examination, assessment of eye movements. So while dealing a case with a vertigo or dizziness, the examination of eyes is very important. So we have to look for range of the movements, pursuit and saccades, and spontaneous nystagmus. So most of the central causes may central and vestibular causes may present with the nystagmus. There is a downward beat nystagmus or gaze evoked nystagmus. We have to suspect lesions of the cerebellar pathway. If there is a horizontal nystagmus, we have to suspect the lesion in the vestibular system. So these are the points we have to examine in the eye in the case of vertigo and dizziness. So one of the range of the movements, another one is pursuit and saccades, another one is spontaneous nystagmus. So nystagmus in different peripheral and central vertigo. So in peripheral lesions, nystagmus is unidirectional. Nystagmus with fast phase beating away from the ear with the lesion. So in peripheral lesions, nystagmus mostly horizontal nystagmus. In that horizontal nystagmus, fast component and slow component will be there. In fast component is away from the lesion. That means if the lesion is in right ear, the fast component towards the left side will be present. So this is the phenomenon in peripheral lesions. Serious class normal చేస్తాం 5 minutes లో వస్తాను. So in peripheral lesions, there is a transient mixed vertical torsional nystagmus in BBP. Mostly in peripheral vertigo, nystagmus is horizontal, whereas in case of BPP, it is mixed and vertical torsional nystagmus will be present. Nystagmus may be inhibited by visual fixation. So if you fix the eye, we can prevent the nystagmus due to peripheral causes. Whereas head impulse sign is present in peripheral nystagmus, and unilateral hearing loss may be associated with the peripheral lesions, peripheral causes of vertigo. Whereas in central lesions, nystagmus is changing the directions. Almost it will be present in rotational momentary. So it is a pure vertical or pure torsional may be present. It is not suppressed on visual fixation. Whereas in peripheral nystagmus, it is fixed with the visual fixation. Absence of head impulses will be there. Whereas in peripheral nystagmus, head impulses will be present. There may be diplopia and dysarthria and limb ataxia will be there in central nystagmus. So these are some tests for assessment of vestibular function. One is head impulse test. Another one is Dix-Hallpike maneuver. So assessment of hearing. These are the tests we have to do while examining the vertigo and dizziness. So audiometry, electronystagmography or video nystagmography, calorie testing, MRI of internal carotid canal. So these are all the tests we have to perform to rule out the vertigo and dizziness. So when you see a case of dizzy or terminal blackout, sensation of movement like vertigo, so these are the labyrinthine, it will relate to labyrinthine dysfunction or central vestibular nystagmus. So if it is a when the loss of balance is there, we have to think about ataxia, weakness, loss of posterior column. All these giant disease or visual disturbances may be present. If there is a lightheadedness is present, pre-syncope, if we subject pre-syncope, so there may be impaired cerebral perfusion or syncope will be present. It may be associated with hypoglycemia or anxiety, hyperventilation may be present with the lightheadedness. So other description include epileptic seizures may be present as vertigo and dizziness. So differential diagnosis for vertigo and dizziness. So acute prolonged vertigo or vestibular neuritis. So this is unilateral vestibular lesion presents with the constant vertigo, nausea, vomiting will be there, oscillopsia may be present and may be associated with imbalance. It is due to sudden asymmetry of inputs from two labyrinths or their central connections. Can be differentiated from BPPV presence of vertigo even when head remains still. So whereas in BPPV, if head remains still, the vertigo maybe subsides. Whereas in acute vestibular neuronitis, even though head is remains still, the vertigo may be present. Most patients recover spontaneously. Glucocorticoids can improve outcome if administered in first 3 days of symptom onset. So benign positional paroxysmal vertigo. So already we already know that BPPV means these are flash-like attacks. So if you change the head position, the severity of BPPV will increase. And attacks are due to free-floating otoconia. Otoconia means debris which is lodged inside the ventricular macula. If you move the head, this otoconia will move, and that will leads to fluid movement in semicircular canal, which produce the vertigo-like symptoms. So to prevent these attacks, one maneuver is there that is called as Eppler's maneuver. So with this Eppler's maneuver, we can fix the otoconia to certain position. So this is the Eppler's maneuver. So turn the patient's head to in a sitting position and make the patient to end of the couch. So turn the head towards the left and make the patient sit in to sitting position in the head in 45 degrees rotated position. So again repeat the same procedure in opposite direction. So this is the Eppler's maneuver. So this maneuver will fix the debris which is present in semicircular canals. So vestibular migraine, this is also one of the differential diagnosis for vertigo. Causes episodic vertigo. Typical migraine headache may or may not be preceded vertigo. Duration of vertigo varies from minutes to hours. Other migraine features photophobia, phonophobia, visual aura may be present. It is treated with the medications used to prophylaxis of migraine and antiemetics. So some of the migraine patients may present with the vertigo and dizziness. So this is called as vestibular migraine. So Meniere's disease. So presence with the vertigo, hearing loss, pain and pressure, fullness in the affected ear. The differentiating features of from other peripheral vestibulopathy and vestibular migraine is low frequency hearing loss and oral symptoms. It is due to excess fluid in the inner ear. So it is initially treated with the diuretic sodium restriction and later with injection of glucocorticoids and gentamicin in the middle ear. So vestibular schwannoma, it is tumor at cerebellopontine angle. It presents with a slowly progressive unilateral sensorineural hearing loss and loss of vestibular hypofunction. On examination, there will be deficient response to head impulse test. An MRI of internal artery canal is required for diagnosis. So bilateral vestibular dysfunction, hypofunction or dysfunction, it presents with the loss of balance, oscillopsia during head movements, as in while walking or riding the car. Causes include idiopathic, part of neurodegenerative disorder or iatrogenic due to bilateral vestibular schwannoma, autoimmune disease. All this can lead to bilateral vestibular hyperfunction. On examination, there is a diminished visual acuity, abnormal head impulse in both directions, and response to caloric testing are reduced. It is managed with the vestibular rehabilitation therapy. Central vestibular disorders, it might be due to ischemia, hemorrhagic stroke, or demyelination or tumors. Acute central vertigo is an emergency in view of the life-threatening stroke or hemorrhage. All patients of suspected central or vestibular disorder should undergo thorough neurological examination and MRI. Psychomatic and functional dizziness. Dizziness might be a somatic manifestation of psychiatric disorders. So, in patients with depression and anxiety, so patient may develop anxiety or other autonomic symptoms due to independent vestibular disorders. So persistent postural perception of dizziness presents with a chronic feeling of fluctuating dizziness and disequilibrium may be present at rest and worse while standing. So these are some differentiating features. This table says of some differentiating features of uh, different kinds of vertigo. These are all already discussed in the previous slides. So what is the main treatment? So these are the treatment for vertigo. Antihistamines like metrizine and dimenhydrazine and promethazine. So metrizine include 25 to 50 mg 3 times daily. Dimenhydrazine 50 mg 1 to 2 times daily, and promethazine 25 mg 2 to 3 times daily. So we can use benzodiazepines like diazepam and clonazepam. These are the sedatives. Anticholinergics like scopolamine and scopolamine can be used as transdermal patch. So physical therapy like repositioning maneuvers like Eplish maneuver. Other treatments include diuretics and low sodium in case of Meniere's disease. Anti-migrainous drugs and methylprednisolone can be used. So selective serotonin reuptake inhibitors can be used as labyrinthine sedatives. So these are the treatment modalities of vertigo. Thank you.